Good morning, everyone. So today is going to be our last week on our ethics going through the lifetime. So we're going to be talking about end-of-life issues today. And then next week, we're going to work on some professional development stuff, including talking about resume writing and letters of recommendation and some things that you might need heading out to clinical rotations. So that'll be what we do next week. Screen. Okay. So end-of-life issues in ethics. And I found this on the Washington Bioethics site, and I really like the summary of like goal setting for caring for patients when they're getting at the end of their life, which is a difficult thing to do. People's goals change. And the first piece of advice they had, which I think is very important, is to really take some time to listen to what is most important to the patient at that time in their life. And some things that they may be concerned about or really want to focus on is one, being comfortable. They want to have decision-making that involves them and potentially other people that are really important to them, caregivers, family members. They need some help understanding and accepting their situation. And that may involve taking some time to really make sure they understand all the information that they want to know about their current condition, what their path may look like, which can be very hard to predict in some kinds of conditions, what they can expect along the way and what choices they may need to make along the way, and then just guiding their understanding and decision making so that they can give us a really good idea of kind of what they, in the best case scenario, would have their end of life care look like. Hospice care can be an important part of end-of-life care, where they really do focus on a lot of those elements that are important to people at their end of life: symptom control, pain control, talking to them about any psychological or mental health issues that they're having. This can be a time where they're struggling with potentially depression, anxiety, loneliness. And they focus on whatever religious or non-religious end-of-life existential beliefs are important to the patient. So let's talk about use this case to kind of have a discussion about what that might look like. So Skip is a 50-year-old man. He's been diagnosed with metastatic non-small cell lung cancer. And he just chose to do palliative chemotherapy because he felt like if he didn't try something, then he was just going to give up. But after the first cycle of chemotherapy, he was hospitalized with fever and neutropenia. And when the provider stops by to visit, he just says he feels terrible and he wonders if chemo is all worth it. But now that he started, he feels like he's too scared to stop. So at bedside, when you hear this from the patient, what kinds of questions might you ask them, or what kind of information would you want to gather from him to help understand where he is at right now? Anybody have some ideas of how they might open that conversation?
I'd first want to know what his spiritual beliefs are, so I would know whether to incorporate that or possibly also ask for, some sort of chaplain or person.
I think we might want to know
I'd
his.
like to- Yep, exactly. His goals or his wishes, what he hopes to get out of this.
If he has any other family or support system that he wants there.
Anybody else have other ideas?
I would want to know maybe what specifically he is worried about stopping, like what scares him the most about stopping chemotherapy.
Yeah, I think, and that might be since that's kind of what he's leading with, that might be a good place to start to find out like exactly what he's worried about, how he feels his current quality of life is and what his goal is. What was your goal in starting this chemotherapy? And that you are allowed to reevaluate if this is meeting the goal that you thought it was going to meet for you. And that information can help sort out like where he is in his mind and what decision-making process he needs to go through. And you could certainly sit and think through all the options. You have the option to continue chemotherapy. You have the option to stop chemotherapy. You could consider hospice at this point. And it might be really important to say, let's explore some of your options, but I'm not looking for a decision right this minute or even today. Let's just kind of plant some seeds of what that process might look like for you and have your goals in mind. Okay. Which kind of opens up the discussion. And in this case, it might have been kind of the next step in the discussion of advanced care planning. So guiding patients who currently have the decision to have the ability to make decisions, to create a framework to kind of guide the future if they were unable to participate in their care later, to help set that framework up so that you or their spokesperson or their family can have a better idea of what it is that was important to them at the time that they were able to be involved in that decision making. So asking them to really think about their values, their preferences. It's important to try to encourage them to discuss that with their spokesperson, their family, their caregivers. That may include documenting that in an advance directive. And it's also important to encourage them to come back and revisit that and think if there's anything that has changed or that they would want to update. And the goals of having this discussion or having patients have this discussion with their family members and caregivers and spokespeople is to, one, help minimize the burden of that decision-making on others who, if they haven't had this discussion with the patient, they're trying to guess what that patient would have wanted. It also can help reduce the likelihood of conflict if they have some specific things that they would or would not want to happen. And they've had an open discussion with that about family members, that can help minimize the likelihood that later there's going to be disagreements among those people about what that patient would really want. And it's going to maximize that the care that happens does really fit with what they would want in their goals. So the times to any time is appropriate if the patient wants to discuss this, but certainly if a patient has a terminal or progressive diagnosis, if they are particularly frail, if they've been diagnosed with early dementia, they're at high risk for something like MI or stroke. Those are times to think about at least opening that discussion or saying, I think it might be a good idea for you to think about what your goals are for your healthcare. You may not be in a place to think about that or discuss that today, but I just want to put this out that when you are ready to discuss this, that I'd be happy to help you think through some of the. So here's another case that can kind of help us think through that scenario. So elderly lady with chronic kidney disease told her daughters that if she ever developed dementia, she would not want to live like that. And then years later, she did develop dementia and ended up moving into a nursing home. She no longer can recognize her family or friends, but she is enjoying the company of other patients and caregivers in the nursing home. The nursing home has a cat. She enjoys spending time with the cat. And at some point, she starts to go into renal failure. And the staff at the nursing home are not very clear if kidney dialysis is going to be something of value to that patient, and asked the daughters whether or not their mother would want to be on dialysis. And so the question is, if you are the caregiver or even the family member who's had this message given to them very generally that if you had dementia, you wouldn't want to live like that, would you consider that an advance directive? And what kinds of questions as a healthcare provider or to the family members, how would you open up that discussion? Any ideas about that?
I think there's probably a lot of open to interpretation of what context the conversation really was set in, and whether, I feel like if she really wanted an advance directive and felt that strongly about it, she would have made one, and just in conversation, it probably wouldn't hold, and it'd be up to the family members to decide.
I also personally feel uncomfortable like assuming that she didn't like grow or change at all over all of that time.
Now, we don't know how long before this that she made that kind of blanket statement, right?
Plus, she might have had some preconceived idea. Maybe at the time they were, they were talking about dementia, and maybe she was just thinking of, had a really negative perspective of it, of how she would be living. And this sounds like she's kind of pleasantly enjoying her time there, and not maybe the idea that she had when she expressed those wishes, like, just being bedridden maybe. And
Yeah, I think that was a pretty generic blanket statement. And it's hard to know whether that meant she wouldn't want to live with dementia, or she wouldn't want to live in a nursing home, or that she wouldn't have any joy in her life if she developed dementia. I mean, there's so many things that could mean. And since it doesn't sound like they had a discussion to further qualify that, it's really hard to take that as, a hard and fast advance directive, unless the daughters do have some more insight into what that could have meant. And yeah, you do, I think you need to take into account what is her current quality of life. Is she really happy in her current situation? And is that a situation where you feel like she would want to have treatment to prolong her quality of life in her current situation? I think that's reasonable to take all of that into current consideration. And maybe they need some more information about going on dialysis. How would that affect her current quality of life? Is that going to put her in a situation where that she no longer has the joy of socializing with the people there, and it's going to introduce more discomfort or pain? So I think they definitely need more information, but trying to tease out as best that we can what would be consistent with what they know of what their mom would want. Any other discussion on the situation? So this is a situation where having more advanced planning or advanced directives might have been really helpful. And when patients are thinking about advanced directives, some questions that might be helpful for them to consider is, do they want this really strictly followed, or is this just kind of a general map to be negotiated? Are they more concerned about the circumstances of how they die? Do they have any particular concerns or fears? If they can't communicate their preferences, like what should be the ultimate goal? Do they want to be comfortable? Do they want to be at home? Do they want life-saving measures no matter what? And thinking about if they can't communicate, do they have someone that they want to be that spokesperson? And if they don't, then doing a living will and really having more discussions with their healthcare providers is very important. So living will is one type of advanced directive. They can give very specific information about things they would or would not want, including do not resuscitate orders or not giving transfusions, where a durable power of attorney for health care is designating that spokesperson to make decisions for them. Different states have different legislations, so advanced directives kind of need to follow state law. So if a person has moved states and has advanced directives, they probably want to update or review them. And patients should know that they retain the right to change them as long as they have that decision-making capacity. But they definitely can't cover every possible situation. Sometimes they can be somewhat vague. And we recognize that their circumstances or time may change this. And so encouraging people that it's not necessarily a one and done document, that they should try to go back and look at it. Okay, so let's look at another case. So you're on rounds. Mr. Wills is there. He has recurrent colon cancer with liver mets, and he's getting inpatient chemotherapy. You note that in the admission paperwork, he has full code status. Given his prognosis, you wonder if this is appropriate and if what his reasoning is, if that is something that he has chosen. there certainly is nothing to suggest that he is not competent to make decisions. So part of the question may be, is this something that this patient has chosen or that has never been discussed with them? So again, like, how would you start this conversation? What kinds of information would you want to find out?
I would maybe point out that I noticed that it was written that way and that this is something that I discuss with all my patients. And kind of see where the conversation goes from there.
I would also want to check for understanding of his prognosis and what he understands about his disease.
And then I want to make sure that he's fully aware of what his quality of life would be if he needed like CPR, and what his quality of life would be after that.
Or even that he understands what a full code means. Because I feel like a lot of people probably don't even know what that means.
And I think we've discussed before that a lot of times television and movies make codes look on the whole more successful than they tend to be in a situation like this. So do they have realistic expectations of if that happened, what the outcomes might look like? So in the discussion, he reveals that one of his goals is he wants to see his grandson get married in 3 months. Would that change your discussion at all with him? How does that inform your discussion with him?
This might mean be something we can discuss other options. Also like hospice, where you might actually preserve a little more quality of life during that time frame than say the chemotherapy and even yeah, he might not know what that is. So
Nothing else, it definitely gives us some insight into maybe why he made that initial choice, if that was a informed decision. He has a very specific life goal here that he hopes to meet. And then it also may open up the discussion after 3 months. Does that mean you would want to have this discussion again? If you live 3 months and successfully see the wedding, then would you still want full code status? So do not resuscitate orders. This definitely comes under the category of patient autonomy. Patients have as long as they have decision-making capacity, they have the right to choose that. We should follow their advanced care directive, or if they don't have one, some states will have kind of this who can make the decision for that patient. If no one is available, then the default is that we should attempt resuscitation unless it's just determined to be medically inappropriate. So the question is, if medically we don't feel like it's futile, but the patient has a DNR order, do they have the ability to make that decision? Seeing some nodding heads. So yes, if they understand the decision and the consequences, then they certainly can make that request. If we have some suspicion that they either don't have the decisional capacity or that perhaps they're in a severe depression or other mental health crisis, then that should be addressed separately. But if we feel like they are making an informed decision, they do have the right to decide that. So CPR can be withheld if there is no, if it's medically futile. So it's likely to be ineffective and minimal potential to provide direct benefit, or if there is a DNR order. Okay. So this is the last case I have for today, and it kind of unfolds all of these different ideas into it. And this is a younger person. So the scenario is 33-year-old woman is in a motor vehicle accident, sustains massive injuries, codes. She was revived after 30 minutes of CPR with multiple shocks. They aren't sure the extent of neurological damage that occurred. She's put on a ventilator. A week later, she's not regained consciousness and develops pneumonia. And while there was some hope early on that maybe she could have some recovery because she was young and previously healthy, a week in, she's not had any improvement. She's been stable as far as her vitals, but she hasn't woke up. The odds of a neurologic recovery are diminishing quickly. So at this point, the care team suggests to the family that maybe they shouldn't treat the pneumonia. And the response from the family member, the father, says, well, each day she seemed to be getting better. Her blood pressure was stable. Her blood tests were looking good. Pneumonia is treatable. Why wouldn't we treat her? So what kinds of issues do you feel like might have been playing into this situation?
It sounds like even though they understand that the pneumonia is treatable, they might not understand that the neurologic function is not going to be there for the same life or like even close to a normal life.
It also sounds like, we're supposed to be optimistic for them, but they weren't giving them the pessimistic side to the story as well, that we're just giving them too much hope that they could come back out of it. But they weren't telling them that there's that great chance with what we're seeing that there's no way to come back.
I think at this point, I would want to talk about like the likelihood that she doesn't recover from like this situation as a whole, and like where pneumonia ranks as far as the options of how to die.
And I think again, television shows kind of play into this. Like you see people are in comas for 20 years on television shows and all of a sudden they wake up. So that's people's like perception of what a coma is when that's not very realistic at all.
Yeah, it seems like they're still really coming to terms with the state of things. And if they're open to it, maybe getting chaplaincy on board.
Yeah, and I think very understandably so. It's been a week, which is a long span of time for the medical providers, but a very short span of time for the family to come to grips with this, especially if there hasn't been good communication. Sounds like the medical professionals have some acceptance and knowledge that they haven't been communicating well to the family. So yeah, I mean, in a situation where there's this tragic situation with unexpected results, you don't expect otherwise young, healthy people to end up in an unrecoverable coma. And initially, they were probably trying to communicate some hopeful signs of this person being stable. But while over time, the medical staff were realizing that there was this diminishing likelihood of recovery, it doesn't sound like that has been communicated well to the family. So why might this have happened? There's lots of reasons why this has happened, and this is something that I've personally seen happen several times, where the providers haven't done a good job of kind of realistically giving the scenario to the family. That might be, it's hard sometimes to decide when is the right time to start communicating this kind of news to families. Sometimes the medical team makes some assumptions about, well, it must be obvious. It's obvious to us, it must be obvious to the family. And so there's this knowledge gap that's been created. And it's not always just the medical side, like we kind of said, influence of other people, media, like you referred to, the people waking up on from a coma on television, or friends and families are probably telling them, you've got to have hope, miracles happen. They are in a very a place where they haven't had a lot of time to come to grips with the situation, a lot of shock, possibly denial. And they may, in the face of a really desperate situation, they may just be have some unrealistic expectations of what medicine can do for that person. So what kinds of things might have been helpful in this situation? So I think kind of back to the talk we had on truth telling, like we want to be as realistic with people as we can and not crush hopes, but we also don't want to build up false hope. So if they had been told initially, she's in a coma, or concerned about significant impairment to her brain, it's unlikely that she's going to have a full recovery. We'll know more about her chances of how much recovery she can make over the next few days. We're going to watch her and kind of giving daily updates on what that looks like. And trying to spend some more time listening to the family about where their understanding is, what do they understand about the situation, talking to them about what the patient would want early on. A couple of you talked about, you know, getting some support in there for the family, social worker, chaplain, other family members, and then setting some time frames of, you know, if we're not seeing this kind of response over this kind of time period, we're going to need to make some decisions. That can give them some time to both come to an understanding about the situation, give them time to think about what they think that person might want, and also kind of signals to them where what the thinking is on that person's status. Anybody have other thoughts about that, or been in conversations with this in your other health careers or even in family? Like, what things might you have seen that have really been helpful in scenarios like this?
The few situations I've seen involving social work definitely helps. I feel that they have the adequate training to speak with the family and different resources. So if you're having difficulty communicating or chatting with the patient about this, involving other services definitely helps.
I guess making this process an interdisciplinary team approach. So using social work, a chaplain, if the patient wishes to have that, or the family, and kind of moving away from our current model of putting this on one person to deliver this news and making it more of a team effort and getting the nurses on board and having them understand. I'm actually doing my capstone research project on this, so. Yeah.
And maybe for some people, it's more helpful to like see the actual data you're looking at. So if the patient had an ECG that was completely like empty of any activity, maybe just showing the family that so that they can understand better what the tests are looking like.
I think it definitely times I've seen these conversations, again, starting back with their current understanding, because I've seen someone try to open a conversation about hospice care or palliative care when the patient or family still were way back at the other end of the spectrum, thinking that, you know, they were going to make a full recovery or that they had many years left ahead of them. So I think it would have been a much gentler conversation to start with their current understanding and kind of bring them along to where the current situation more realistically is, before jumping into end of life care planning with patients and family members who are not in that place yet. That wraps up our lifespan of ethics. Do we want to take like maybe a 10-minute break and then jump into some hematology stuff for ClinMed? Okay, so about 10:50.
Do you want us to just stay on this link?
You can stay
then?
on this link, yep.